If I haven't met you already in a different sewathon or a different conversation, my name is Jana Zwyman, and I'm the founder of Mass for Humanity. And what that is a hub for organizations of essential workers and vulnerable groups that need cloth masks and are requesting them, and for makers who are making them. And it's a place that's, for makers and people who need masks, but also it's really about a community wanting to help each other. And one of the most exciting things about Mass for Humanity is meeting all these incredible makers. And one of our makers, Kirsten Jaglo, who is here today, has probably made over 400 masks, is always a regular at the sewathons and also a scientist. So we were talking about how there's such a confusing amount of information out there, and how great would it be if we could get scientists to actually just talk directly to people and answer questions, to be able to take the data that we know and the data that we're trying to figure out and how to apply it to our lives in the middle of the pandemic. Mass for Humanity, we're massforhumanity.org. And also at the end of this, probably tomorrow, we're gonna be sending you a survey to find out how this went and how to get more of your questions answered. We'll get right to it. I'm so excited to introduce you all to Dr. William Pewen. I'm going to read this so I get it right. Dr. William Pewen has contributed to combating infectious disease as a scientist, educator, and policymaker. He is the 2003 Congressional Fellow of the American Society for Microbiology and served as Senior Health Policy Advisor in the US Senate while the nascent effort to establish pandemic preparedness and biosecurity began. He holds both a doctorate in infectious diseases and microbiology and a Master of Public Health in Epidemiology from the University of Pittsburgh. And he has made significant contributions in both vaccine and drug research in HIV. Dr. Pewen has served as a professor of public health and family medicine and has directed both research and teaching programs. His publications include study of vaccine and drug treatment, as well as pandemic response. And his publications include contributions to Science, the New York Times, Health Affairs, and The Atlantic. So Dr. Pewen, thank you so much for being here. We are going to be starting with his presentation and then opening it up for questions. Thank you so much, Dr. Pewen.
Thank you for having me. And first thing I wanted to say as I sit down with all of you is, for all of you who've been constructing masks, thank you. 15 years ago, I sat down when we first started what was supposed to be pandemic preparation. And I remember sitting with the Navy in one of these classified briefings and then building strategy and so forth. And one of the things that came up was, do we have the proper supplies of things? And it's devastating to go 15 years down the road with all the work that so many of us have done and find that a lot of this just didn't work for a variety of reasons. So, I have a couple of friends who their families are making masks and taking up that slack and really the initiative. And I made one. I have a sewing machine I bought to work on my canvas on my boat. And that was about 2 months before this all happened. I thought I could just try making a mask. And I thought, I don't know how, I would not get much productivity done. I'm okay with canvas, but I appreciate the effort that all of you make. And, this is really a lot of the success of this effort is going to be in 3 areas. And one of them really is the health providers who are, in some cases losing their lives doing this effort. If you haven't watched the Frontline episode that was out this week about Northern Italy, it's just heartbreaking if you watch and see what's happening around the world. I think that the second side is the people who are working in science trying to make vaccines. We've got 70 to 100 candidates right now. And the third, frankly, it's unfortunate that it's not just here. A lot of people, I'm not talking politics, but both China and the United States, administratively, governmentally, at the top leadership levels, did not do what we needed them to do. And it's the people at the grassroots are that third leg of the stool. I mean, people are doing amazing things. And this is just one example of that. So thank you. It's appreciated. I want to begin with a couple thoughts because, this sort of, some of my friends have said, oh, this is your time. And, you're epidemiology, you've worked in containment, you've worked in, you're familiar with epidemics and I was in clinical care when HIV broke out. I was in Los Angeles. We didn't know what it was. We had patients dropping around us, didn't even know about the virus to begin with. So this is not, in a sense, a new thing to me. But there's two things that have come to mind over the last few months and working with especially the clinical folks and the public when people call me. And you know how the inquiry starts. It usually starts with the phrase, "I've heard that." And then there's the whole, you think, well, I either haven't read that or I know that's wrong and how do I explain it? But the uncertainty of things is really getting to people. And the only Secretary Rumsfeld quote I've ever used, but it's a good one, and I give people their due, was that idea about there are known unknowns, things we know that we don't know, and there are known knowns, things we know we already know. But it's the unknown unknowns that get you. And it truly is the case here that there's so much we don't know about this virus. And you see Dr. Fauci on the news saying, we don't know, this is a new thing, we're learning. And that makes people very, very unsettled. So we have to make the best decisions as we go. The decision, if you asked me 2.5 months ago about masks, I wouldn't be as enthusiastic because we didn't see the virus being as transmissible as it is compared to the other SARS viruses, and it is more transmissible. And there's a couple other things I'll share with you that you'll see why I said, no, we know it had some benefit, but this is something we really need to do. But really the other aspect of all this is risk. And if you ask people, what's the riskier thing, flying on a plane or getting hit, the likelihood of getting hit, say, with lightning. And people don't really understand those things. But more than that, they're not tolerant of risk. So in my lifetime, I've seen an era where everybody had their kids vaccinated. And then over time, more people didn't want to have the kids vaccinated. They said, there's some risk here. And they couldn't really navigate the risk very well. And that's a problem we have right now. Should I go to work? Should I go to school? To me, going out and getting a tattoo or going to a bar is not a high priority. But each of these things involves risk. Going back to work involves risk. And so we're going to have to learn how we navigate and make decisions, the costs and the risks to each thing, the benefits that we have. We're going to figure out, though, that we are in control. I think that's sunk in to a lot of folks. We should be in control of this. And on an individual level, mask use is one way of doing that. And that's really, it started out grassroots. It certainly wasn't, initially handed down via the government. So want to show a picture here for a moment. And the reason I picked out this particular picture, I've spent thousands of hours in situations like this gentleman is in, or in the suits, with the masks and the face shields and multiple levels of gloves and gowns and so forth, dealing with monkeys that were infected with viruses that would kill me within a week. Now, there's a lot of talk right now about apps. Oh, we could track people with apps and we could try to contact trace this, that, and the other. Well, if the over here on the left, this is a person and not a virus, the app would say you're so close you're going to die or something's really bad's going to happen. But we mitigate risk. So you can see he's got the double gloving going. It's over his sleeve. He's got the gown on. The particular hood that he's working under here actually has airflow that is designed to suck air in, filter it, and send it out through a HEPA filter. The air doesn't go out. It doesn't come to him at all. It's set up in a certain pattern. So it's actually pretty safe. I've spent many years working in this kind of environment. So being able to deal with that kind of risk and understanding that we can control the situation, I think is real important. And the phrase we keep using is mitigation. We don't eliminate the risk, but we do all these things to make it so that he can work with something there that may be very dangerous. Okay. I want to talk for a few minutes just about the nature of the epidemic right now. And I give this briefing once a day in a much longer form to different agencies to try to give them a spin on what's actually happening. Currently, we've got almost 5 million. This is updated as of yesterday, 5 million infected individuals in the world. That's an estimate. Those are the reported cases, the people who've been diagnosed, been tested, been assessed, and about 323,000 deaths. So it pretty much is everywhere. There's no place that it isn't at this point. You can see countries where you can say, well, they must be doing better than us. Russia has just exploded, at least in reported cases at this point. So regardless of what we would ever do in the United States, it's going to be out there and it's going to move around. And so we have to figure out how we're going to deal with that. In the United States, this is not how many people are infected and contagious right now. This is how many cases we've had. And this is where the initial debate became very interesting, because if you look here, it says we've got 1.5 million cases with 91,000 deaths. And the interesting thing is that that ratio of deaths to cases has been about the same all along. It was about 5%, and then they did some adjustments in how they classified people. It became about 6%. So that is, when people talk about that's almost twice what we had in the Vietnam War, and it's still rising. An annual flu typically will cost us about 40,000 lives, sometimes a little less, sometimes a little more. We are not at the level of, say, the 1918 flu, but that's partly because we've mitigated it at this point, and it certainly isn't over either. The most important thing, though, as we look at are two. One is that if you look around the map, you can see that based on population, wherever there's population, there's cases. And there are some areas that are particularly hard hit. And living in the DC metro area, it really is the DC-Boston corridor that is inordinately hard hit. But you can find cases everywhere. And when I was consulting with federal folks, I said, you know, they were thinking about what would happen in the rural communities. I said, as soon as someone dies in that county or nearby, people will become more aware. It's kind of like when we had the, Vietnam War, Iraq War, and so forth. Once a young man died when I was growing up, suddenly all the mothers were talking, and people got engaged in that particular issue. So at this point, everyone knows of someone, maybe close to them, maybe not so much, and this is a real problem. And so that's one part of it. The other part is that a number of us looked at data early on and said there's always some cases that don't get reported. Well, sometimes that's because they're not that serious. They didn't need to go to the hospital. And many of you remember the commercial where the Surgeon General and Dr. Fauci were saying, if you get sick, call your doctor. They didn't want you to flood the emergency room because first you may not have COVID, you may have flu, and then you go in and sit with COVID patients and you might wind up with COVID. That was one concern. The other was, overwhelming the health system. So a lot of people never came in, yet they had the disease, and they didn't get counted in this 1.5 million unless they got tested later, and a lot of them didn't. The other thing is that we have an awful lot of people who don't show symptoms. Now that's really important to what we're talking about today. At a conservative estimate, and what my colleague and mentor at University of Pittsburgh in our department, he asked me one Sunday, we were both actually calculating at the same time based on the Chinese data. I said, I think it's about 5 times more individuals than what we've counted because we have triaged people from coming in, and some of these cases are very mild, or they don't even have symptoms. So that would mean instead of 1.5 million cases, we would be looking at 7.5 million cases if I do my math right, my head right away. It could be as high as 10-fold higher. So we may have 15 million individuals who've had COVID infection. That's really different than most of the respiratory diseases that we see. There aren't that many asymptomatic. But that also means, do you know that someone has it or not? Or did they have it and not know? And that's really key to what we're talking about today. Okay. I'm going to mention a couple terms here because they get used and bandied around and they're not familiar to a lot of folks. I use the term sometimes social measures when I talk about things that don't involve a drug or a vaccine or going to the hospital or getting some kind of a biopharmaceutical treatment, for example. Other individuals use this term non-pharmaceutical interventions, and they're basically the same thing. It means things that we can do in public health that we've done for hundreds of years actually, to try to control infectious disease. And some of these principles have even been applied to chronic diseases. But for today, let's consider new disease like this. What can we do to prevent it from spreading? And can we stop it? Can we suppress it with public health measures? So this is classic, epidemiology 101 that we teach students. The first thing we want to do is test and identify who's actually got the disease. And what did I just say that makes a little bit of a problem there? If you're not showing symptoms, and many of the cases don't show symptoms and don't get tested, they're mild asymptomatic, and if you don't test, you don't find them. So someone you work with, a neighbor, even a family member may be infected and you don't know. But we need to test in order to find those individuals. Second, if they are infected, even the people who don't have symptoms can be spreading disease. We want to isolate the infected so that they don't have contact with the uninfected. So that's the first thing we do. And then the next thing is we want to of course, track all the people that have had contact with them. And that's where the real meaning of quarantine kicks in. We've used quarantine pretty loosely in this pandemic. Quarantine really means that someone we think's been, we're confirmed has been exposed to someone who's infected, actually is quarantined, set aside for the incubation period to see if they become ill. And we've said it's about 14 days maximum for this disease. So we want to have them quarantined for 14 days. If they don't become ill, now they can mix in with the uninfected people. Of course, it's not working well because a lot of the people have never been tested. We don't even know who all the cases are. So if my mentor from Pittsburgh were here, he would be ranting and we wouldn't be able to shut him up right now because he's been on this from the beginning and he's absolutely right. And I said, yeah, but I can't really change that right now. We are not sampling people who don't come in with symptoms. I mean, you have to sort of fight to get yourself a test. Remember, everyone can have a test if they want it. Well, they couldn't. And we weren't going out and sampling people randomly to figure out, well, how many people have it and don't know about it? So that's what we would be doing to if this broke out tomorrow and it was brand new in Wuhan and there were only 50 cases and each of them had, say, 30 contacts, we would isolate the 50. We'd contact those 1,500 other people. We'd get them quarantined, and we might be able to stop it. But when you reach the point where you've got hundreds or thousands and they travel, what happens is you can be around the world in 24 hours. So this thing seeded itself very quickly outside of Wuhan. And then once we started seeing a couple cases pop up in the US, where President Trump said, well, there's only a couple, it's going to go away, it's going to burn itself out. No, those were the sort of the tip of the iceberg cases. At that point, most of us in public health said, we're never going to stop this with non-pharmaceutical interventions. It's everywhere. It's going to start popping up in numbers. We can blunt it, and that's where you start hearing the term, bending the curve. But what are we asking people to do now to help blunt it? Because we're still going to try to test, we're going to isolate, we're going to quarantine, but how do we blunt this? Well, social distancing. It's a respiratory disease. It's not HIV. It's not something else where there may be physical contact. It's just proximity, the use of the mask or PPE, all the personal protective equipment. We talk about hygiene and washing and cleaning surfaces and washing your hands and so forth, but there's also rest and nutrition. So those are all the things that before we had antibiotics, our health was improving, our longevity was improving, and it wasn't because antibiotics were there, because they weren't. It was because we got better food, we got better rest, we had sewage treatment, water treatment, we got clean environment. So it's the hygiene hypothesis, as they say. These are the things that are still very helpful, but we will not knock this out purely with this. We're going to need to use other things, but they're buying us both saving lives, keeping the health system able to cope with this, and they're buying us time while we get that vaccine and those drugs out there, which is really one of our ultimate goals. Okay, I keep using the term new normal because I don't hear it enough anymore, and I'm wondering if people in policy are really have sort of put it almost in the back burner. They're thinking of going back to the old normal, and that's not going to work. So, as I've sat down with the agencies and talked to people, this idea of effective control is real important. So, how could we control this in an ideal situation right now? What would it take? Very low levels of infection. Because if I'm going to track and trace people, I can't have 1.5 million people who have 30 or 40 contacts apiece means I'm suddenly contacting, tens of millions of people. And then when some of them are infected, I've got to multiply that. And I did a quick little back of the matchbook calculation online and told some people, you'd have half the country being tracked and traced. So that's not going to work. But if we had really low levels of infection, it would. If we have enough hospital workers to treat everyone, if we have enough public health workers to track those folks and to teach and advise, and if we have enough tests, we're good. But as you see, infection is asymptomatic, the incidence is high, that doesn't help. The ability to treat and trace is limited. We would need hundreds of thousands of trained public health workers. We don't have those people. Tests are suboptimal, and we don't test many people. 3% of the public's been tested. That's it. And that's actually assuming everyone was tested just once. Some people get tested and then get retested to see if they're now well. And then ultimately, we're going to need the drugs and vaccines. So I don't like to say back to work, back to school. I'm going to say recovery. we're going to have to do something. And I'm going to drop in family history here. Both of my parents were Depression era babies, and one fought World War II. And I was kind of raised in a certain environment. My mother's uncle actually worked for FDR and Truman in the White House. So I was kind of drilled, and I went to military trained. So there you go. But the idea that we can do things, it was ingrained in me. And one of the things I mentioned the other day, one of the congressional people, I said, we built 92,000 planes in World War II in 1 year. In 1 year. Why can't we make these little plastic test kits? So I think it's possible for us to do what we need to do, but between the two extremes of let's just all go, to a stock car race and then go down to the beach and maybe go to a bar and act like everything's normal, and the other extreme of we'll stay home for 2 years and it'll be fine. There's got to be a middle ground, and we can probably move to a new normal. So here's the problem. And I'm going to refer to Ebola for a moment. We've all heard about Ebola, I'm sure. And this is not Ebola, thank goodness. With Ebola in West Africa, about 11,000, I forget the exact number of people died in that epidemic. But you probably don't know that more people died because of the Ebola effects, but didn't get Ebola. And what I mean by that is the health system shut down, the economy shut down. If you needed cancer treatment, if you needed malaria treatment, if you had hypertension, if you had any other health problem, you didn't get treated. So right now what's happening to us is we have individuals who aren't getting cancer screenings, who can't get proper care for all kinds of chronic conditions. And we are probably going to see whatever the number of COVID deaths equaled or exceeded by the other causes of death because your doctor's telling you generally don't come in the hospital or don't come to my office right now, and we'll manage this from home. We'll try telemedicine. So this is going to be an impact we got to worry about. Of course, people are worried about their livelihood, and government has made a big step up to try to help people with that. But we're going to have to find a way to work, and that means new normal again. And then, are the kids going to go back to school? Are they going to use Zoom? We don't know. But in some areas, as Tony Fauci said the other day, it's possible in smaller towns and communities that children could go back to school and the risk would not be that high. And then finally, I don't want to say people are going to go nuts, but civil stability is an issue in terms of people being locked up, especially, we've even heard stories about, in abusive relationships or people with mental health issues or whatever happened to those people who we were so worried about in the opioid crisis. So we're going to have to figure out how do we cope and sort of chew gum and walk and chew gum at the same time, as they say. Deal with COVID, get us to a vaccine, minimize the harms there, but not cause even more harms by not taking care of the other things. And that's an incredible challenge. There's not a lot of rational talk going on about it, but that's why we need things like masks and social distancing and new ways of working and all those things, just like our Zoom here. I'm working with people I've never met. I'm working on contracts with people I've never actually seen except via Zoom. So that's part of the new normal. KISS principle, keep it simple. This is a respiratory disease. We do want to wash our hands. You touch surfaces, yes, you could pick up virus from that, but the number one way this thing gets from person to person is through the air. I got to the point a few years ago, I've always, for 20 years, not always, but last 20 years, gotten a flu vaccine. I was forced to at first because I work with monkeys, and they were more concerned about the monkeys getting sick from us than us getting sick from the monkeys sometimes, I think. But the concern, I'd be on a bus and somebody's coughing or sneezing. I get to the point I said, I'm going to hold my breath, step off the bus, go to the next bus or something, and avoid that, whenever I could. I wasn't wearing a mask, but I would avoid that coughing, sneezing, whatever. And I've gotten the point on Metro, sometimes I'll take the next train or I'll take the next car. And many of us have done that sort of thing. So it's anything to reduce respiratory transmission, coughing, sneezing. Yes, I'm talking right now. If you were right in front of me for the whole hour, that might be a little bit of exposure. So we're trying to minimize individuals from releasing particles. And I won't argue about the size of the particles. All the scientists want to do that. They say, is it droplets or is it aerosols? It's both. And I don't want to inhale them. So what are we talking about? A barrier. We're talking about a mask, really. How well do they work? I don't want to argue this until I'm going to give you a range because there's a lot of good evidence out there to argue that we should use them. And I'm going to just build the case here for you, but I cannot give you a black and white answer. Again, back to the uncertainty. Okay, empirically, just looking at how things have gone, I actually flew into Taipei, Taiwan, right around the time of SARS. I was leading a congressional delegation. I had a little bit of a sinus infection, and as we were flying over the Arctic, I realized, oh my gosh, if I have any fever at all, when I get off the plane, they had infrared and they were sensing your temperature without even walking up to you, and they would quarantine you. And I thought, I'm the head of the delegation. I swallowed a bunch of aspirin. I said, I got to make sure I don't have a fever. I know this is a sinus infection, but I don't want to have to explain this to the embassy and all these other people whatever happened. Or there we called her a trade delegation. It wasn't an official embassy. South Korea, Taiwan, Japan, Singapore, those countries are doing pretty well. And they're doing pretty well because they learned things in the last SARS epidemic. They learned how to, and they didn't use just one strategy. Mask wearing was one of them. But if you look at the countries that used masks and that went through SARS, it's kind of a combination of things. They're not just doing masks, but that's one part of their arsenal in terms of how they've tried to control this. And so those countries have done reasonably well. The other thing is I look at laboratory studies, and a number of studies have been done using, and what is a homemade mask? I'm sure I'll have questions. We'll talk about fabrics and so forth, but using homemade mask or materials, let's say whatever they thought was representative of homemade masks. What we've seen is if you're talking about the very smallest particles that, really the N95s do so well, and here the KN95 does well, these will pick up 95% of all of that. A homemade mask might, for the very small particles, only pick up about 30% of them and block them. But generally, of the particles we're most concerned about, they'll pick up or screen out 50 to about 90%. And an N85 only does 95. So you can be very close with a good one. So that's the comparison that we see in the laboratory. The next question is, what's really most important when we're dealing with either a production mask or a homemade mask, but particularly the homemade ones, is that what we're trying to do is we're trying to prevent the individual who's speaking, coughing, sneezing from exposing others. Now, there's a kind of a behavioral, you could imagine a behavioral problem here in that you have to be motivated to protect other people, because what I'm saying is if I wear this, I'm protecting you. It's not so much self-interest, although I will get some protection from other individuals. It's primarily catching, you don't even have to have a good seal because it will catch the particles from your speech right into the fabric. So that's really effective. That's where we think most of the benefit is. Now, the problems come around the fabric, and I'm going to talk about a couple things about fabric in a moment, and fit issues. This actually works fairly well because I can actually tighten it around me, and it's pretty snug, and I've got filter material in it, and it's good. This works incredibly well because it's actually made to conform. It goes right under my chin. They've got a little metal clip here that kind of forms it around my nose, so it seals better. So the fit is part of what makes the homemade mask a little less effective. The other is the actual fabrics you're using. I'm very concerned about masks in general in terms of reuse. And you've heard about healthcare workers who've been told to reuse their masks. I have heard people told to spray them, I use heat, and I'm going to show you how I use heat myself in terms of not damaging the mask by using some heat to kill the virus. But over time, reusing a mask, you're expecting it's going to degrade, and if you wash a cloth mask, it's going to degrade over repeated washing. So government agencies right now that are issuing the cloth masks are saying, wash it 15 times no more. After that, we worry that there may be some gaps in the fibers and it may not be as protective. One of the things that we always see come up is if a person's wearing a mask, will they do things that increase their risk? Behavioral compensation is the word people like to use. So in other words, if I'm wearing a mask, will I go to a bar and get in a crowded space? Well, first up, I don't think anybody's going to wear a mask in a bar. But will I go to a Nats game and say, well, I'm safe now? I don't know. But it does give you control. Now, generally, we think that people don't do that very much with any kind of a protective device or prophylaxis. But my argument would be, if you're needing to go back to work, you're really concerned about your mortgage, this, that, and the other, and it's 3-4 months down the road from now, and you say, well, there is some risk to go to work, but I can mitigate most of it with the mask. Yes, that's behavioral compensation, but it's allowing you to have a livelihood, or it's allowing you to maybe take care of a parent or whatever. So it is a way of, I think that it's a kind of a false thing to worry too much about the compensation. We don't think it's a big problem. And the whole purpose is to reduce risk so you can do some things you couldn't do otherwise, I think. All right. In terms of design, I have a little picture of the one I have here, this KN95, very similar to the N95s. The pattern shape kind of optimizes your performance. You're going to see picture mine, and I've kind of waved the blue one up here. This is not a pattern. Those of you who sew at all, you could do a much better job than what I did here. This was like a 5-minute job. A Navy friend of mine came over. He says, "Oh, you bought a sewing machine. You're doing canvas." I said, "Well, I'm going to make a mask on that." He says, "You're just looking for something to do." I said, "No, we're supposed to have them now, and I think I should have one. I don't want to use an N95 just to go out and get groceries. So I'm going to try this and see what I can make in 10 minutes. It wasn't pretty, but you can all do better patterns, anyone probably, than I do. I'm going to make fabric suggestions, simple ones. High thread count, that just makes sense. You don't want sheer or really low thread count fabrics because you're not going to have the protection. CDC says something on their website that bothers me a little bit. They talk about using a t-shirt. That's the last thing I would use. I would just not use it. I'm just thinking what my t-shirts are like, and they're much more porous than I would like. Of course, I just had some ties that I used on mine, and I would do this differently now because if I had elastic, I would have done the elastic loops. That's going to form fit better. And as we have in the picture here, the KN95 it's just a little thin, and I don't know what to call it, where you would buy one, but I'm sure that those who do extensive sewing would go, "Oh, I know where I can get that kind of thing." This is just a bendable little metal, like aluminum piece that allows you to shape the nose. And that's a real nice thing that they just use an adhesive to put on there. If you do as I did and you put some kind of high quality filter material inside of the cloth, you're going to get the added protection I mentioned to you. On average, 50 to 90% of the benefit of an N95 from the cloth. What happens when you put in a filter? I haven't seen any studies. But to me, it's the additive benefit of the filter material inside of the cloth. So I think that if you have high quality, and I'm going to show you a chart in a moment, you're going to get something very close to an N95. And I will tell you, this is a lot more comfortable, this kind of fabric to wear, than this is. I've spent too much time in those containment facilities. They're not pleasant. So here's kind of just a quick picture of what I constructed there for you. Dual materials, it's a microfiber cloth, and I said HVAC filter pleat. I removed, what I did is I took one of those 1x1 filters. You've all seen the ones you put in your furnace, and I just took one of the ones that just has the little pleats in it, took the box apart, took the metal off, just peeled it off, and I had a sheet of high quality filter material left. And that's what I just folded into pleats and stitched it in. The chart here shows you when you hit that N95 level. There's something they call FPR, and there's another rating scale called MERV. If you go to Ace Hardware or to Home Depot, if you ever need filter material, you could buy a big filter box. You don't need to buy a little one. You buy a big one, it's cheaper, and just rip out the material that you need. Anything about 13 or above, coupled with cloth, is really going to be close to 95% for these air particles up to about 1 micron to maybe up to 2 or so. That's the size that we think in terms of it's not the virus itself that you're catching, it's virus that's attached to some liquid, some saliva, spit, whatever you want to call it. So anything about 13 and above will give you really good protection. I can't give you warranty on performance because we haven't done these kind of studies yet, but you're really replacing to a great extent the N95 in that case. Now, you can't wash this. So we get to, how do we maintain these darn things? But the first thing I'm concerned about, though, is if you go out and use your mask, whatever kind of mask you use, and you come home, what do you do with it? And with mine, I have a problem. I have really nasty stitching on one side, and that's my reminder which is the inside and the outside. Because one side's going to be contaminated from someone else. The other one, if I don't know, maybe I've contaminated with my own breath. So what I want to do is just decontaminate this when I get home. And with a straight cloth, you can wash it. Soap will do it. Warm water will do it. Not a big deal. Very easy to kill the virus. You read all these things about it living on stainless steel, this, that, and the other. Yeah, but I don't lick my stainless steel in my oven. You know, I don't lick my fingers. What I'm concerned about is something that comes against my face or touching my face or someone getting very close talking to me. So I'm giving you an idea here. The washing is going to degrade fabrics over time, and it's going to destroy filter material if you put it inside. So heat is my solution. And this chart here is a whole lot more data than maybe you want, but it'll give you an idea. It will give you a warning over here too. Your refrigerator may be as low as about 4 degrees Celsius. I converted one of these and convert all of them. And if you put your mask in there or anything else you brought home, you didn't clean it off, that just lives on there. Anything that's a number here is a virus count. So you bring your carton of milk home, it's been handled, you put it straight in your refrigerator, and you know, I'm not gonna lick the carton, but that's not disinfected. So my stepdad has impressed me. He wipes everything down when he gets home from the market, and he says, well, then it's clean. This is body temperature, and you can see that unless it actually gets in your body at body temperature, eventually it dies, but it'll live for a day or so. But what if you take it up to 133 degrees? In other words, like record heat in Death Valley. It's not real hot. And I found that if you do this for an hour, that's way beyond what's actually necessary. And I set my oven at 140 degrees. So every time I come home, I just set this inside, turn it up to 140, and I'll show you here. Don't take the pizza out first. I make sure the oven's clean. I do this, and when I'm done, I preheat my oven, so there's not going to be any virus living in there. I won't tell you it's not possible to do something, but really, nothing's going to live there. I like this approach because I don't ignite it. I don't turn it up to 220 or something. I don't damage it, but that'll kill the virus. And I just set it for an hour, which is way more than is needed. But you can look at that chart. You can make your own decision, like how hot do I want to get it? Well, 133 and 30 minutes, or actually you could probably set it, you know, at a lower temperature for a longer period of time, but I don't want to take forever. So anyway, that was a nice little thing that we learned from very early on in terms of what kind of condition will kill the virus. This is why I'm also a little optimistic we're going to get a bit of a break this summer as it gets hotter. If you look right now where there's inordinately low infection, it's across the Southwest. Arizona is not near as high as you would predict, particularly in Phoenix, for the population that's there. El Paso, West Texas, Southern Texas. And so I'm hopeful as that heat comes up, we're going to get some benefit from that. That if we all run into movie theaters and sit, you know, jowl to jowl, we'll undo that. But this could be helpful. Okay, so no pizza in the oven. You have to wait till later. I've got some references here. I've just put down 4 that I think are really helpful. CDC has their page on the use of masks for COVID. Like I said, I'm not big on the T-shirt thing. I've got something here about how viable this virus is. So if you want to know how to disinfect, what does bleach do? Don't drink it, please. All of that. 3M has a nice actual handout here about the different other kinds of masks that other countries make and how they compare. And they're all very, very close. And then if you want to read an academic review, the last one there has all the arguments pro and con, and well, maybe this, maybe that, and you'll wind up really confused by the time you get to the end of it. But I wanted to make sure I had enough time to answer some questions. I hope that was a good introduction to kind of like the state of the epidemic, what we think we're trying to do, what's actually happening, and how you can kind of empower yourself in terms of reducing your risk.
Great. Thank you.
Thank you
so much. It's I feel as if you answered so many questions that were already on the list before you came to talk to us. So thank you. And I love the example of the oven at 140 degrees. I think that's fantastic.
Not all of them do that. I noticed that, you know, I got at Breville, I bought the same one that I bought for a friend for a wedding or a wedding gift. And I said, you know, I didn't know an oven, but this one actually goes down to 120. So if you really want it lower and just longer, you can do it. A lot of them won't go quite that low. My electric oven only goes to 170, so that would be kind of high, but it's an option.
Got it.
Yeah.
So there were definitely some questions about masks, and I think you answered a lot of them. One had to do with a filter pocket and the best kind of filters to use, which I think you answered with it sort of is part of your answer, but if you're doing it as a filter and something to put inside of a mask, say you have like it's a pocket or a pillowcase,
Yeah.
and you're putting in the filter and you
Mhm.
take it out to wash it, is there a certain, does it have to fill the entire inside of the mask for fit? Or if it's a little bit smaller and it's just in the area between your nose and your mouth, is that okay? Or how should people be
If you're going to take it in and out, that's a little different than mine's actually stitched to. Actually, it fills the whole space. So there's a seam here at the top and a seam at the bottom, and I've stitched the.
Okay.
I've done very tight stitching of the microfiber to where it's now a pouch. There's no opening anywhere, and in between there is a layer. If you're going to open it and close it, somebody will make a zipper. I hadn't thought about that. I haven't tackled zippers with sewing. You know, you could actually dispose of your filter over time that way too. So if you decided, well, I want to wash the cloth, but I obviously don't want to wash the filter, so every couple of weeks I'll just replace the filter. Well, that would be fine.
Okay.
But I still think it's good to disinfect in some way, and heat was the easiest way I saw to do that.
Got it. And then in terms of killing the virus, there was also a question about whether sunlight will kill it. Like, could you put your mask outside? Could you leave your mail outside? Is that something that you would recommend?
I wouldn't use that because I don't think I can control. Now, if I lived, my father grew up in Tucson. I've been to Tucson during the summer. You could probably set it out in a rock and it would do it.
Mm-hmm.
I don't think I would use that as a reliable way to do it.
Mm-hmm.
Now, some of you may have seen they were showing the New York subway on television where they were trying to flash UV light, you know, the blue light. Some of you've seen that. And we use that inside, like that picture I showed with the gentleman working on the biocontainment hood is what we call that.
Mm-hmm.
You don't actually flash and kill them that quickly. If they're actually just flashing it once, that's not killing anything. You need to maintain that UV light for a period of time. It's not healthy for humans.
Mm-hmm.
So again, you don't want to be looking at it. You want to be exposed to a lot of it. Some people use UV light in these water purifiers. That's one step in water purification people like to use.
Mm-hmm.
It could work. Someone asked me a while back and I said, I just don't think many people, I was on LinkedIn. Someone wrote me and said, what about UV light? Because I actually posted my oven picture there. And I said, well, I don't know how many people on LinkedIn have a UV light at home. That's the next question. So they might be like, you all have a thermometer. Thermometers, they give them away at health fairs. Thermometers have been selling for $10, $15 a piece for $2, $3, $5 thermometers. So I don't want people to go out and spend $100 on a UV light unnecessarily.
Got it. And on that topic of sort of equipment, there was also a question about.
Oh, I should mention too, UV light doesn't penetrate some fabrics, some synthetics.
Okay.
I almost forgot that one. That's the kind of the caveat that's kept me from ever saying anything about, you could consider UV light, because someone may pick a fabric that it doesn't reach through and it doesn't get the virus. Again, these are just, we're taking and using combinations of preventive steps. It's not that any one thing is doing it, but we don't want to leave holes.
Yeah. So the general idea is basically mitigating the risk versus being able to eliminate all of it, because we don't get to live in perfect lab settings.
Exactly.
Okay. So talking about lab settings, there was a question from Stephanie about the science behind a new antiviral coating from University of Pittsburgh. So maybe you have an inside know about textile materials. Do you have any idea about that? Have you heard about that at all?
I've been on the horn with my colleague up there talking about the vaccine they're working on. And of course, everyone has a vaccine. But no, I have not read anything on that. And now I can, if someone's interested, I can try to get the inside track on that and just send me the message, and I will see what I can find out.
That sounds great. Other questions we have, there are a lot about children and grandparents. We have some, and also kind of going back into like the disease itself and understanding it as a respiratory disease, but we're now seeing a lot of headlines about children getting sort of effects that are like Kawasaki disease and, rashes on toes and all these things that we don't necessarily associate with a respiratory disease. But how does it work, and sort of how do we understand sort of all these different things that are happening? It's like there's a new symptom every 2 or
And now, yes, and I'm going to put on, I've spoken with folks, and some people have talked about this, and I think you've seen I've tried to draw a middle ground in our strategy.
Mhm.
Someone asked me, say, well, what's the worst case scenario each direction? And I said, well, the worst case scenario about bending the curve is that if we're not developing immunity, or it doesn't last very long, and coronavirus immunity tends not to. I said, and if we don't get a vaccine in a couple of years, we could have more people die if this drags on for 5 or 10 years. We could actually kill more people than letting this just sort of, they say, burn through. I said, but that's not morally acceptable. So we've got all these things we don't know about the virus. And I said, and the thing that's really the big tipping point is every week there's something new. I'm kind of exaggerating maybe just a tad, but there's something new that comes out that we didn't know. Remember, young people weren't supposed to get sick.
Mhm.
And if you go online and watch the Frontline episode from this week, it's just heartbreaking. The people in the hospitals there in northern Italy, and one of them was a young man who's maybe 20 years old, and he almost died. One of the, not to get too techy, one of the aspects of this is that the receptor, the cell receptor that the virus attaches to enter, is represented all through the body. So it's in the brain. It isn't in the eye. So people call me about a particular tissue and they go, well, what about this? And I have to go look and check my chart and go, there aren't really receptors for the virus there, but it's in ovaries and testes. It's in the entire GI tract. It's in the liver. It's in the heart. I started my career in cardiology before I studied infectious diseases. And we've had a whole lot of individuals who now have cardiac effects from this. And sometimes it looked like they were having a heart attack. They ran them right to the cath lab, and they were going to do an angioplasty, or they're going to do an open heart surgery. And they looked at the vessels and they were clear. And they realized that the heart muscle had been damaged. It wasn't damaged from a blockage, it was damaged from the virus. So there are some of the things that you're seeing are due to, that's where there's a receptor. In other cases, like Kawasaki's disease, COVID-toe, some of these other things. And some of the people who are dying in ICU are dying not from the virus directly, but you've heard the phrase cytokine storm. Your body becomes so hyperactive immunologically, and some of the drugs that we now use for things like psoriasis that you see averages DV that cost $30,000 a year, they actually bring down the immune response. So that's one of the strategies right now, is if people are having some of those symptoms, we try treating the symptoms, but there are multitudes of disorders now. They're not the most common things, but there are all kinds of sequelae from this infection that we're learning more and more about. And then we're also seeing that some people, they really don't recover totally. There is lung damage and other things that happen. So even if we say it's severe, but you get over it, well, maybe you don't get totally over it. So that's the really concerning thing. I was, like I said, I mentioned earlier, I was in the VA system working when HIV hit, and we found out that HIV was connected to cancers, to dementia, to other things that we didn't realize initially. So we have to be very, very cautious, but
Got it. And
that's the clinical.
with with the caution, you had mentioned something about the immunity kind of length is being pretty low. Like at some point early on, I was like, oh, maybe if I got COVID, then I'd be a superhero and I can give blood and everything will be fine.
Yeah. And you could work safely in environments you didn't think you could. Right? A lot of people think that.
Wouldn't that be fantastic? But a lot of the information that's coming out now is that immunity isn't necessarily that, definitely not forever is sort of what we've heard, but sort of how, if someone does get COVID and they go through the process of recovery, do they have immunity for a certain amount of time? Do we know? Or is there...
You bring me back to my monkeys.
Think about that kind of risk.
What we know from the first study that was done was they infected rhesus macaques, the monkeys we use in research a lot. And then when they recovered, they challenged them with coronavirus. They infected them, and none of them got ill, which was really encouraging. People said, oh, you mount an effect, because we don't mount an effective immune response to HIV. The body doesn't clear HIV. And there are other pathogens like that you just don't have a really good immune response to. So when we talk about creating vaccines, the first thing we say is, do people survive this infection? So that was the first thing. We go, good. We don't know if immunity is durable. And I'm fascinated that Dr. Fauci uses that term the way we all do in the field, meaning it lasts. I had smallpox vaccination when I was a kid. I got it again about 20 years ago. I had to go through the Defense Department, all these things to get it again. I did not have the same immunity. It was kind of weak, what was left. And so we know that that wanes. That's a real concern in terms of whether and usually when you're infected, you get a stronger immunity than you do from a vaccine. That vaccines have to be boosted. So there's a warning there that even when we get a vaccine. Now, I have to mention this because I don't want anyone to go away with the impression. If you get tested and they find that you have antibody to COVID, that does not mean you're immune to COVID. There are so many different antibody tests. There's so many different kinds of antibody. And Dr. Fauci's even said there's antibody you can develop that makes the disease worse. And dengue fever I think he's mentioned that one. It's a classic in medicine that we all know. Just having had it does not give you either protection or anything. It just means you've had it. Eventually we'll know better. We'll know what a good response is, and we'll say, oh, that's a good response. Like I actually was exposed to rabies and got the whole, the immunoglobulin, the shots, the vaccine and everything. I felt like I'd been hit by a truck. It was 27 shots and I hated needles, and my mother said, I don't know how you went through that. But now I'm hyper immune to rabies, and I know that that's strong. But other things wane. I probably, if I was going to go in developing world, I'd get a Hep A booster. So this could be like flu. It may be good for a year. We're hoping the immunity if we get a vaccine, we're hoping that vaccine's good for a couple of years, because how are you going to immunize someone in a rural Mexican village and then find them a year later and make sure they get their booster? This is hard. It'd be harder in Bangladesh, where they're having a typhoon there now, or cyclone. So what are we going to do to create a vaccine? We're going to want the ones that last for a few years if we can.
And we also got a question about asking you to talk about happy hypoxia and silent hypoxia, as well as the use of an oximeter.
Facts. Now, the oximeter is a fascinating means of. The other thing there's two things that are changing in treatment that are really interesting. One is when someone's infected but they're not terribly symptomatic, there's an argument made to put them on an oximeter. Normally, when your PO2 drops low, when your saturation drops below 93, 92% or so, you start to get symptomatic. We have people, there's a famous picture already of a woman with her cell phone out texting who's at like 80% saturation or 74% or something really ridiculous. And I'm like, she should be in distress. And the problem is there's something happening that they're not experiencing distressing symptoms, but then there's very little margin and they crash. And so the idea is to monitor folks that way. This is another weird thing. The other thing is that we're finding that a lot of physicians are concluding that going straight to a respirator is not a helpful thing, or a ventilator rather.
With, there have been a lot of talks about how, when kids go to school, they might get their temperature checked at the door, or a lot of people are getting temperature checks. Should they be getting oximeter? Should everyone have an oximeter?
I don't know that we've seen that in children. Okay. I think that we've seen that. Now, I didn't mention this because it's usually the part of the longer briefing. Who's really suffering here and who's getting hospitalized? I think you all have a pretty good idea of this, but let me just recapitulate it. Most overwhelmingly, the individuals who are hospitalized are 50 plus. At 65, there's another big break point. And the reason for that big break point, and I worry about Dr. Fauci every day, when we reach a certain age, we've been exposed to a lot of different infectious agents. And you have these, what we call naive cells that haven't really decided what they're responding to yet. And they respond to that particular agent or that infection. And then there's memory cells, and you have antibody and you have immunity. As you get older, there's fewer and fewer of those haven't been taught cells, and they start to die off. And essentially, when I get to be 80, as Dr. Fauci, I think, has just turned or returning, I don't have as many. And so those folks are at higher risk. From 65 on up, that's a big thing. From 50 on up, we start, and part of this is due to also cardiovascular disease and diabetes that increase our risk, and there's various reasons for that. So we're looking predominantly at older folks. In the younger folks, I don't think we've seen this syndrome to that extent. I certainly haven't seen any case reports on it. It may be happening. The younger patients, like you said, we see this Kawasaki disease type syndrome, and it really is, it looks immune activation related. Now, good news, I don't think anybody's been hospitalized for COVID toe, but COVID toe, or what's loss of sensation? Here's my test. Does anybody remember the story? What loss of sensation should be kind of a tip off that you might be infected? Loss of taste and smell.
Mm-hmm.
If suddenly nothing tastes anymore, if you don't have other symptoms, that may be enough reason to get tested right there. So again, now that to me makes you wonder, I've seen no papers on this, but what's causing that? And is this, again, there are receptors in the brain. So is that a, oh gosh, I don't get any respiratory disease, I feel fine, but I may wind up with some kind of long-term brain damage? I don't know. It's just so many things we don't know.
Got it. And sort of within this world of, so much that's so unknown, we've got so many, just sort of simple things this is sort of a question about so many different questions, but one about like joggers and jogging and exercising. I've got a lot of those because an article came out about, how far the aerosol and the droplets go, and should people be worried about when a jogger passes them? And
I started wearing a mask because I think I was freaking people out down here. I run the Anacostia River, and this came up over a month ago with a physician friend. He said, well, he picked up a paper someone's, and they have the little models with the little particles showing where they're going and everything. And I said, well, you know what? He said, well, what do you run? I said, yeah. I said, I hold my breath when I get close to someone, about 20 feet away. And when I'm about 20 feet past them, he says, oh, it's like an anaerobic workout. I said, yeah. And so I feel like I don't want to breathe in because they're not wearing a mask either.
Mm-hmm.
And I don't want to breathe out because I don't want to expose them. And so it gives me a little bit of extra stress. But yeah, I've gotten to the point now where I run with a mask, and I don't know that people are responding any better. But there was a point about 3 to 4 weeks ago where I saw people getting really kind of freaked out. But also, if the wind's blowing, this dissipates really quickly. And yes, you spread particles when you speak.
Mm-hmm.
But I got chickenpox in my 30s on a United Airlines plane from a small child who was coughing and sneezing next to me. I know that's the one that gave it to me. I just that's sort of a gut level thing. But just talking is not as high a risk. And going across a bridge and passing someone for a few seconds, probably not. But I walked into Target to get some grocery things I needed after a couple of weeks, and there were a lot of people around, and I got kind of weird after a while. We're all getting to the point we're not used to being around any kind of crowds, and everybody had masks on, and I still wanted to get out of the store. There were a couple of things I had to get, and I wanted out, and I thought I should just have them delivered. So we're getting a little bit, this is the part that's really sad, I think, for all of us, is if we were told the virus are gone tomorrow, how would our relations with one another be? Would they be the same? And that's going to be hard. I had grandparents who raised kids in the Depression. They never were the same about money. There were permanent issues about security, economic security. We're going to have some issues too. Mm-hmm. So I just thought to myself a while back, if it makes people comfortable, if I think I'm going to run into people, if I know I'm going to be not near anyone, I'll skip the mask. Mm-hmm. But if I think that I'm going to be on a jogging trail, biking trail, and run into people, then I'll put the mask on. I go, it's fine.
Got it. Thank
you. I think that's really low risk, but if it makes people feel better, I think that's something we got to do for one another.
Got it. And I've gotten a couple of questions about pools and using swimming pools.
Oh, Jonas Salk it's the image of Jonas Salk and polio now. And of course I went to school in Pittsburgh, so that's a big thing for us.
Yeah, and thinking about swimming, and personally, I miss swimming a lot.
I bet.
When you think about sort of you breathe out into water and you think about droplets and aerosols.
That chlorine.
Is that chlorine just strong enough to
The-
keep
the-
it apart? Or would you
yes.
be concerned, or like weight, or so how would you kind of think about that as a risky behavior versus not a risky behavior?
You know where the risk is? The risk is around the changing room and the restroom and that kind of thing, and the socialization around the pool.
Got it.
I mean, I think you could be swimming next to someone else doing laps and you probably wouldn't have much risk. But it's the ancillary contact around the pool, it's probably the real risk there.
Like if you touch the ladder for the pool and you climb up that, or
I'm really just thinking about respiratory mostly.
Okay.
I am, and maybe the restroom, but not so much the water and the chlorine levels they maintain. If a pool's properly maintained, or they're going to kill this thing pretty quick. But yeah, I understand the anxiety.
Got it. We're in the anxiety question hour.
Oh, it's fine.
Which is so helpful. Thank you so much, because it's, we're
Happy
all
to do
trying
it.
to sort of figure out how do we take all this data and live our day-to-day lives and know what kind of risks we're taking. Because, before coronavirus, if you walked out the door, something could happen too. But it's sort of like what.
3 weeks ago, if I took a walk or a run, or I was out in the park across from my home, I could walk up to someone's dog and I could talk to people and I could pet their dog. They don't even want me to pet their dog anymore.
I know.
My neighbor's fine, but people are they're anxious.
Really anxious. And so
Yeah.
having more information is really helpful. And
Yeah.
we just got a question from someone who's 70 years old, who's really concerned about going to the store for supplies, even with a mask. Is sort of the short time in Target, even if it feels kind of.
I'm not a.
Would you?
I didn't like the feeling in Target, but I've gone to Giant, I've gone to Safeway, I've gone to Trader Joe's. They meter their stores, so they now have a thing where they have you stand and they make sure there's spots in the sidewalk 6 feet apart, and then they meter that, and they have everyone's put up the Mylar or the plexiglass boards and so forth. This is the disparities issue. I'm going to mention that because I don't know their circumstances, but this is not striking people equally. And the other disparity, I mentioned the older folks, but I want to mention another disparity. In all age groups except below 5 years of age, African Americans and Hispanics are over 50%, and in one age group, 75% of the hospitalized people. They're still a lot of them are still having to go to work, or they live in crowded households, or, there's a whole lot of probably risks that are involved. So some people can afford to order their groceries and others have to go get them. And so this is where I think we can help one another in terms of that part of things. Get the groceries for your relative, see if a group will deliver them. There's also I looked at this because I thought, well, I'm old enough to qualify for one of the markets to go in early. But, the early hours at 6 in the morning. And I was like, oh, no, I'll go with the millennials. I'm not going to get up at 6.
Busy too at 6 in the morning.
What's that?
I've heard that they're very busy at 6 in the morning too.
Well, yeah, I made the mistake of going to Giant up on H Street. That's a younger neighborhood and so forth, on a Saturday at 4, and it was chaos. They actually had people packed really tight on the sidewalk, but the store was more open. And I just thought, this isn't good. But this is where, for the peace of mind, if it's an affordable thing, pay the $5 or $7 delivery charge. I like to pick out my own produce and that kind of thing, but right now for people, it's really not worth it. But there are the special hours. There's, turning to groups that may bring things to you, that kind of thing. I understand the anxiety. I do.
Yeah, and as a shout out to the groups that have been much more impacted by COVID than other groups. On Mass for Humanity, a lot of the organizations that we have serve really vulnerable populations. So anyone who's watching, there are a lot of really systemic, difficult issues that we all have to face. But if you want to make a tangible difference in a couple of minutes, you can make a mask for someone in the Navajo Nation, in the inner city, for groups that serve people with HIV specifically, and a lot of healthcare clinics that serve very poor populations who are often essential workers who have to go out and work.
I appreciate you saying that, because it's not of all, we're getting COVID coverage on television to the point that it's not good for our mental health. But that problem has not been mentioned enough. That there are groups there that are really devastated by this, and there are groups that are higher risk, and there are people who struggle with this. And someone I used that quote the other day in a government meeting. I said, well, there are people who order their groceries, and there are people who have to go get them. There are people who work from home and Zoom call, and there's those that have to get on Metro. And so it's disparate. And that's why I think all of these strategies to be able to work safer, they're most important to those folks right away.
Yeah.
But it's helpful.
Absolutely. And for people who, have the ability to stay home and be on Zoom calls, or, stay in a very safe place and order their groceries, we've had a lot of questions, which include both elderly and children, which is, how can grandparents see their grandchildren? Which
I was still thinking about that one, because you hinted at that earlier. I was made myself a mental note. Make sure we talk about this.
How do grandparents think about it? And people like me who have a small child and parents, and it's really amazing, because within sort of my age group, there are a lot of people worried about their parents, and a lot now about children because of these news articles that are coming out. And the last thing we want to do is hurt our parents with the love of their grandchildren who might be a carrier.
Well, one of my friends just had one of his parents. It's the beginning, I think, of the dementia problem cropping up, and they're both elderly. And he just drove cross country to go out and see them, because somebody had to take care of them. And I can tell you, this is where I say it is not a matter. I don't want anyone to misinterpret when I say we have to find a middle ground. I'm not with either of the extremes. We can't let people fall through that. The health system is not functioning for a whole lot of people who don't have COVID right now. So he's out there trying to cope with this problem. And I said, this is not, I've been where you are. He's about 15 years younger than me. I said, I've had that with my mom, yes. And then you say, am I going to pose? I still have her husband who's mid-70s. And I keep thinking, I need to look in on him, because I don't have any siblings doing that.
Yeah.
But will I pose a risk to him if I fly out to California? Honestly, flights don't bother me at all right now. There's 15 people on the plane. They're all spaced out. It's much better than going to the market. Everybody wears a mask. You get screened, and you got HEPA filtered air. That's as good. That's better than my apartment building with all my young, neighbors, and they have to company. They wear masks. But I said that's no more dangerous. But it's still, it preys on my mind. What if you got sick after I got there? Now, the long-term care facilities, I think you hear this from all sides, because the basic assumption that that's the last place we open up. It is just, you've got people in tight quarters. You've got people at higher risk. When my mother got old, she said at one point, she says, I take 7 medications. I said, at your age, and you can't use that phrase. I don't want to hear it either as I get older. But at her age, that was average or below average. So you've got people with multiple. How many people are hypertensive in the United States? It's around 40%, because they keep changing the definition of it. But in a long-term care facility, you got people with multiple chronic diseases. Advanced age, so their immune systems are not as strong as they once were. And then you bring in children. Actually, we keep thinking that immunizing children may be the first line. We've got to that point with flu, because we said anyone who had a child in daycare or in preschool or just even primary grades, they come home with every bug under the sun. And if you've been a teacher, you're sick for a period of years, then you seem to be immune after a while, because you've seen it all. Those children are a tremendous risk. The grandparents want to see them, and we've had those heartbreaking pictures through the windows and so forth. We're going to have to figure a way. And I was really impressed with all of my frustration with Congress sometimes. Someone that I least expected it from, I heard, was talking about how do we improve the environment in the long-term care facilities so that people have the socialization, and how do we do it so we don't pose a risk. So that it's a concern. I don't have a magic bullet for any of that, but it is the most vulnerable population.
Got it. Thank you. I know your time is precious and everyone's time is precious. We have a follow-up question on that. Or actually there are two, but one I really like in particular, which is it okay if someone else pets my dog? Like how?
I wouldn't get upset about it.
Okay.
Again, you know, you're talking about, we don't get infected from a handshake. We get infected from someone putting their hand someplace it shouldn't be, and then doing a handshake, and then you taking your hand and putting it place somewhere it shouldn't be, right?
Mm-hmm.
So there has to be like 3 or 4 events for that to infect you. I wipe the virus, I shake your hand, you touch your mouth or your nose. That's what has to happen. So I would not be terribly concerned.
Okay. And another one is about sort of schools and summer camps, which is, and also wearing masks at summer camp. So there have been some things that are published that like kids will go back to school, but they'll have, you know, safe distances and wear masks, or they might go to camp and everyone will wear masks. Do you think wearing a mask, like, do you think it's time to be going back to summer camp? Maybe, and whether people should be wearing masks. And I know that's a huge question, but maybe to break it down even more is, you know, should kids be wearing masks who are over age 2, kind of out and about?
You know, the concern is, can you get a small child to understand and to comply with social distancing? Look, anyone who's a parent understands that. Now, here's my, you know, I've had some very concerned parents, and one the other day was talking about a long trip, and it was connected to the kind of scenario I just described that all of us seem to go through with our parents, and they have multiple children. And I finally sat and said, you know, one scenario, I talked about you could fly if it was just you, and you could do this and you could do that. And then one scenario I came up with, I said, you know, you could approach this as sort of a quasi-vacation for the kids. Because you're going to take the kids, where could you stay? What could you do? And no, they're not going to go to summer camp, but we can do an alternative, new normal kind of experience. Maybe we stop at, you know, Grand Canyon's open. Maybe they can get to see the Grand Canyon, but no, they're not going to take a hiking trip with a bunch of kids into the gorge. But, you know, you find a new modification, a new way to do it. I don't think many summer camps are going to operate, or they'll operate for older kids. Above a certain age, and they'll operate for some activities but not others. Could you go horseback riding? Yes. Roughhousing around the pool? Maybe not.
Got it. But swimming laps would probably be okay.
I think, you know, now I see people pushing, you know, I'm getting ready to turn on the television tonight and see an ad, you know, those lap pools, those little tiny things where you swim and that blows the water by you. You know what those are.
Yeah.
And so that's the next thing I'm going to see. You know, that I saw, has everyone seen the mask commercials? They're on television now. They got this, what you can buy, it's like the Ronco mask or whatever, and they're showing something that looks a little like this. And they say, but it's $20 for 10, but if you order now, you know, and I don't know if they're any good. This going to become a cottage industry in all the little workarounds and things that we do. But I'm a skeptic on the camps, but there are alternatives.
Okay.
My generation wouldn't have coped with this so well. I mean, a lot of younger people, I've got a friend who's like 20 years younger. I said, what are you doing right now? He says, well, I'm killing a 12-year-old. And what he meant was he was playing video games, you know, and he's online with all these different age people, and they're all, and I said, you know, I just didn't really want to live in the matrix. You know, I'm not like I have to be the life of the party, but I want to interact with people. But we're going to have to interact differently like we do here on Zoom. You know, it's not the same, but it's certainly better than a phone call, and it's certainly better than other alternatives.
Yeah, and it's so wonderful to see your face.
Yeah, it is. It is. You know, it's our contact. I see people when I'm down here at the marina. I keep social distance. I see my neighbors because I have to run the condo association, but it's different.
Yeah.
And, you know, now you all understand the psychology of the mask thing, because there's all that with, you know, does the president wear a mask? Does so-and-so wear a mask? Does this, that, and the other? It's similar what we went through 20, 30 years ago with condoms, where we said, you know, why don't people just use them? You say, well, here's two people who are going to have an intimate relationship, and they say, I want to get really close to you, but, you know, and so it's kind of contradictory. And so you look at a politician. I worked for a senator, and I've explained this to some of the fellows, the young staff. I said, you know, it's going to be hard because I don't look friendly. I don't look like you want to vote for me when I've got this on. You know, it's like that. It's not intimate. And that's our mouth, our face, our eyes. We're going to have to get better with our eyes. It's tough. And so that's part of the behavioral scientists have got to get more involved in this. I really haven't seen enough on that. They will understand this.
Yeah, and I keep asking you more questions. And
That's okay. I'm okay.
Still here, so
you're keeping me away from snacking for dinner. It's fine.
It's really just amazing. I've had personally, I've been kind of gathering these questions from people for a little while, and I mean, there are so many about inside versus outside now, because we've seen the studies from the restaurant where people who are, you know, the sort of that downflow of air seemed very, very scary and dangerous. Do you think people are going to start, you know, in the new normal situation, do you think you're going to see a lot more people eating outside or kind of outside of like HVAC systems where air might circulate again? Or is it really just people staying distanced?
Yeah.
How do
Restaurants are a problem, but I actually posted something on LinkedIn, and I can include it in the slide pack. I can add the slide. Because I want to stay on masks and not go there. I taught a few years ago as a chair at University of District of Columbia, and as I walked into my office, they hadn't shown me my office. It was a real mess. But then after a week, I discovered I had some papers lying out. They became covered in black-green aspergillus mold in one night. And I have asthma. I had faculty who had much worse lung problems. And I'm like, what on earth are we going to do? And the whole building was just sick and rotten. And so, you know, I'm sitting there going, I have to do something for me immediately and see if it works. Then I have to see if I can dig up the money out of my meager budget. And I bought, you know, big HEPA air filtration units, about, you know, 2 foot high and 2 foot wide. And they work great. They cost $135 a piece. They cleaned up the air. And so the other day I'm watching the CBS Morning News, and some of you probably saw the story or saw it in the evening where they're showing, well, look at these models of how the air goes through the restaurant, and someone who's far away is actually getting infected. Okay. You know, we can say we got to tear the whole building apart. Or we can put in a $135 unit with a HEPA filter and activated charcoal and everything else and filter that room and turn that air over every 8-10 minutes, and there won't be a problem. Or, as they did at the end of the story for a moment, open the window. So there are solutions, and they, you know, one of the things that has been, I don't want to use the word lie, but been kind of representation is that we keep talking in the media about how we need this tremendous technology breakthrough. The test for coronavirus is PCR amplification. It's basically taking a little bit of the genome and trying to multiply it. And when you see enough, you go, oh, they had it because it wouldn't have multiplied otherwise. We've been doing that for 30 years with viruses. It's not new. We've been doing antibody tests for years. You know, we have to develop one specific to this. And we've been making vaccines for a long time. This is all within our ability. Putting some air filters in a restaurant and putting more than you think you need probably is adequate for the short term to mitigate the problem. It might actually be worse to be outside if you're packed close together than being inside and having filtration equipment working.
Okay. And if you're stuck on you're taking a bus to work, you have to go to work, do you just open the bus window, try to sit by the window and just open up the bus window if you're on a bus for an hour? Is that
if they let you open the bus window?
You?
I think what's happening is this is going to give mass transit a real kick in the teeth.
Yeah.
I don't want to get on Metro myself right now because there were other environmental issues there before this, but people are anxious about that. Yeah. And if they think they can flash a UV light for 1 second and disinfect a car, that really worries me about the New York Metro now, or the New York subway. So I think that we had a ridership in DC, a ridership decline over the last few years on Metro, and I think it's going to continue now because that is something that's really hard to do anything about. you definitely want to wear a mask in mass transit. I'd wear an N95 in that situation if I could.
Okay.
But a lot of people are going to drive, but more and more of us are going to realize that we don't need to be at work 5 days a week.
Mm-hmm.
I know a lot of folks who are, 75% of Washington, D.C. it's unlike anywhere else in the country. 75% of us are essential. No, it's way beyond everywhere else. So that means that people are going to work, or they're telecommuting, or they're going in 1 day a week. I have friends in the Navy who do have to come in 1 or 2 days a week.
Mm-hmm.
And so you stagger the hours, you drive, maybe a carpool, you wear a mask, you mitigate the best you can. But it's, I have a little chart, maybe I can send to you, Jana, that I put together for some of the governors and local government folks. And the idea was, instead of saying, this is the formula we use to roll out and to go back to normal, look at your community and what's important in your community and to your people who live there. And then look at the risk benefit, to each, look at the two axes. And so I gave an example. I said, well, I can go backpacking. What's the risk? We closed down all the parks around here. What's the risk of me going backpacking on my own this weekend? 0. It's really 0. Okay, but how about a pickup basketball game? Besides the fact that I'm so short, I won't compete well in basketball, and I'm not that coordinated. But
still.
Look at still. If I thought I could, the contact and the proximity, it's a totally different risk. So you say, you know what? I want to have some kind of sports activity. I'll cycle, I'll go backpacking, or even I'll go backpacking with a friend, but we're not going to share the same tent. Mm-hmm. So there are ways we can accommodate those sorts of things. Work, recreation, church. I have a lot of friends who I thought that church would be a real big deal and it'd be a problem. They go, oh, I've been doing church online for 2 months. It's fine like that. And they're not in a hurry to get back. Okay. And they live in the deep South. And I'm like, well, I thought this would be a big deal. Mm-hmm. They've adapted. Yeah.
And kind of bring it sort of back to sort of people going out. Mm-hmm. In terms of mask wearing, when you leave the house, would you wear a mask just because you're outside, or is it when you see other people, or you're within sort of like eye gaze of another person for sort of the social contract or the public good that everyone's protecting each other, or do you wait until you're somewhat closer? Like what do you recommend people? How should people be wearing masks besides properly and cleaning them appropriately?
Right.
But sort of under what conditions? Like, should they be wearing them in their backyard? Should they be wearing them as soon as they cross their, property line or get to a more crowded area? How should we be thinking about that?
I think that the behavior I'm going to start adopting, because I had an awkward moment yesterday. I want to walk. I've said I've been working all day and doing the Zoom calls and whatnot. Mm-hmm. I'm going to go walk across the street to this huge park next to RFK. And everyone's got their dogs out there, but everyone's way distanced apart. And what happened is I thought, I'm not going to bring the mask. I'm just going to walk through the park. I'm not going to be next to anybody. I went around the corner, and a retired DC policeman who knows you pretty well started chatting me up. And so I started moving. We were more than 6 feet apart, but I started calculating in my head while we're talking the wind and which way is it blowing. And I don't want to be downwind to him, and I don't want him to be downwind to me. And, it's kind of wearing. And I thought to myself, I'm just going to pocket one of these in my pocket every time I go outside. And then if I feel like, I'm going to be more closer to someone, we don't want to wear a mask and then just increase risk and get really, really, really close. It mm-hmm. defeats the purpose. The etiquette really hasn't yet developed. And the more we say that you're protecting the person who's not wearing the mask, I hope that works. I do. I hope that it becomes like a kind thing we do for one another, and it becomes a social norm. I don't really like it being the law. I know it has to be, but that part is, it doesn't feel good that we approach it that way. Mm-hmm. But yeah, it really hasn't developed. 6 foot rule is reasonable. Mm-hmm. I always am aware of wind, but I'm aware of that because I probably was a runner for so many years, and I'm anticipating. No simple answer.
Well, I agree. I really appreciate your not simple answer to that because
You know, you look at the,
how does it
if they have a mask on, you can't see their mouth, but I would say look at their eyes, and you could,
Mhm.
if I see any anxiety, and I'm not sure that the mask reduces it, because you know when how did we view people wearing masks a year ago? They must be sick.
Often, or very afraid of getting sick. One or
Yeah,
the
they're
other.
sick or they're weird. You know, that was kind of how people really looked at people wearing masks, and
Yeah.
that's going to change. Our social norms are going to change a bit.
Yeah, culturally within the US, wearing a mask before coronavirus
I
was
I forget who said this to me the other day.
was
They said if we made American flag masks, that would help. If we made masks that, you know, I actually told some people from one of the agencies, I said you have to go out and visit people. You should have some great message there. But I don't know. It's hard to do.
yeah, and it's, we're navigating new territory and sort of how we're interacting with each other in so many ways. And one of the things about Zoom, which is so nice, is we get to see each other's full faces and like
Yeah.
really full expressions,
Oh,
even
it's
if
so
it's like
nice.
over the
That part's so
screen.
nice. And I don't know how many single people are on the call, but there's been some hilarious pieces in the New York Times and some other places about, you know, the number of people who are on dating apps trying, they're lonely. Any of us who are single, would like to be dating or seeing someone.
Mhm.
And so they're doing, you know, it's actually slowed down the dating process, which is kind of nice and healthy and all. But then they, a couple of them wrote about, well, we finally had sort of a date where we both got food. We sat socially distanced apart and talked. And then I think the one woman, she says, you know, after a while, I just started to think, I really like him, but I don't know all his family. I don't know who he's been around. And, you know, it was like, oh my gosh, you know, so all these new anxieties.
So yeah, so many other things that are going on now, which is just, yeah, it's super tough.
So, and you know, I remember the end message was the first kiss is a really, really big thing now. It's like we're back in the 20s or 18 somethings. They're going like, it's not like we're married, but it's getting closer. So
Yeah,
it's just really fascinating. The
yeah.
change, the
The
change.
way the people who I know who are single, the way that their relationships have been evolving during this time has been it's been really different from a couple months ago.
It's going to be very interesting for the sociologists to say how this pushed us apart, but how it built bonds and intimacy at the same
Mhm.
time. Yeah, I think we're going to see both.
Yeah, one of the things I've really experienced with Mass for Humanity is really people's kindness, because we're a community of making for other people, and often the other people are people who really need, who need help, and it's a way of just giving in a way that's wanting to be received,
That's why I wanted to mention that right up front
which
when
is
we sat
really
down, because it's
really
a
amazing to do.
giving thing. Yeah.
Yeah, and it's I've been able to meet so many makers who are just giving of themselves, and being really creative with the materials they have and sharing, and just sort of this beautiful sense of what community could be, and such a lovely model of how we could move forward and take care of each other and care about each other, and just take knowledge, take knowledge and just apply it, and think about how we can all be protecting each other and kind of move into this new normal, and hopefully bring good stuff forward versus just kind of a lot of the anxiety that we're feeling right now.
Well, that's why I mentioned at the beginning. I flash back, and you know, you get to a certain age, you become your parents, and I'm thinking about what my mother would have said, and
Mhm.
all the stories about how they got through the Depression, they got through the
Mhm.
war, and this, that, and the other, and you know, I've got a picture on my desk here on the boat, actually, in the nav station, of my uncle with FDR, and I'm thinking about the very first fireside chat he gave was when the banks collapsed and people had taken the money out of the banks. And this was on PBS the other night. They went over it and they said, you know, he actually asked people, he sort of shamed people and said, you know, it's really not fashionable, but some people have taken their money out of the banks. And he was having the Treasury print money, because back then it was cash. It wasn't, you know, credit cards and everything. And people actually went back on Monday and put their money back in the banks. There was this feeling of unity, and we are in this together. And
Mhm.
however you get there, and movements like this are part of that, really. It's very helpful.
Yeah,
And we just become more and more divided, you know, country. And I said, you know, the, senator I worked for was always sitting in the middle, and it became such a lonely place. At the end, she was about the last one there. And I said, you know, most of America is there, but we've been drawn to these battles, you know, where sometimes they say, well, what's the point of that argument? I mean, where are we going to go? And I'm a scientist, but I frequently talk to people at AAAS and other places and say, well, but is that really, how's that? Because I've worked in the clinic and I work with veterans and I work with, you know, people with HIV and other things. I said, you know, how is that going to change the life? You know, I really identify with the clinicians. How is that going to make a difference? And this kind of movement really helps that way. It helps bring people together. It meets a definite need. You know, my preference would be that we didn't need to make these, that there was plenty of things being made. And you know, if anyone is interested, if you go to help.senate.gov, they had a hearing the other day. It ran 4 hours, but it was the second witness that was the most fascinating. He was only on for about 45 minutes. He was from Dallas. He makes masks and PPE. And he talked about, I've been trying to get you to buy those in the United States for the longest time. And our drugs, our PPE, our masks, this isn't, you know, anti-trade, anti-China, anything here, but we just don't have the most essential things accessible. And when push comes to shove and there's a crisis, you know, the leader of China, or if it's Poland or anywhere else, they're going to say, I got to take care of my people first. We've got to be able to take care of people. And so we should be able to produce these things. But in the interim, you know, I know many, many people who are doing just what a lot of the people in this group are doing, and that's, you know, meeting the need.
Yeah,
So,
and doing the best. It's really amazing to be around people doing the best that they can. So it's someone just said that it's basically crazy that this needs to be happening, and I think it's outrageous that we're making cloth masks for. Originally, it was healthcare workers. A lot of the people who are working in healthcare are giving them now to their patients, so that their patients are okay in waiting rooms and they're sending them home with them. But also still for healthcare workers. And it shouldn't be that way. At the same time, I'm really grateful for all the people who are stepping up and just saying, what can I do? How can I help my neighbor? How can I help, you know, people who are trying to help people? So I think in that way, it's really it's a time that I think we can kind of harness what we're doing now towards the future and kind of laying that groundwork of, you know, more of a sense of the public good.
Well, it's really helpful. There's some things that we do, they're not informed by any science. That's the thing I really love about this series you wanted to start. And I think that's helpful, is to get the scientific basis and so forth. But there's an expression, I didn't like it when I first started in the Senate, but it was, don't make the perfect the enemy of the good. I'm kind of a perfectionist, but the reality is we cannot afford to make the perfect the enemy of the good. And that was kind of the point I was making the other day, posting, and I'll send you, like I said, that slide of the air filter. And I just pulled out my credit card at Lowe's and bought one. And once I realized it worked and it cleaned everything up, I said, I'm going to use the department budget and buy 5 more. Nice. And it's not the same as fixing the building, but that was $40 million, and Mayor Bowser had not given the university money to fix their buildings, and there was hundreds of millions of dollars in deferred maintenance. So, you know, and this is the reality, though, of our priorities. Maybe they'll get straightened out. Is that the priorities were not to prepare for this. No one rewards you for buying life insurance or health insurance. They really don't. They don't reward you for saving or preparing for a disaster. They don't reward you for, you know, getting the sandbags ready for the flood. But when you need them, suddenly every politician, every leader comes out and says, oh, I'm behind this, but they weren't behind it 15 years ago. So maybe we won't make this mistake again, but hopefully we won't make similar mistakes again either. It will be a little more thoughtful.
Yeah. Well, you know, thank you so much for your time.
Thank you.
Really,
no, I'm
really
glad to. And if there are other questions, just you can email them along. I'm happy to answer them.
Excellent. Thank you. Yeah. Thank you so much. Thank you for everyone for coming, sticking around. And yeah, if you have any other questions, you can send them to me at massforhumanity@gmail.com.